Hello there. Welcome to the 100th episode of Dr. G at the Heart of Healthcare.
Exciting.
And the crowd goes wild like the World Cup. Welcome to season 4, episode 9 of Dr. G at the Heart of Healthcare. It is my 100th episode, and I have to bring back my hospice bestie, Dr. Lauren Templeton, to the show. Looks like, have you been watching soccer today? What's going on here?
Yeah, you know us, we like to celebrate life and be real people. So today, Argentina played and it was a close game. I was literally giving education and trying to make myself not look over at my phone to be like, who's winning? So Argentina won. So happy World Cup.
Happy World Cup. You know, my husband was over here screaming while I was trying to be on the phone and be, a professional community member. And he's like, go. Isn't it fun? Yeah. So welcome back to the show. The title of this episode is State of Hospice.
Woo! I feel like we've had this type of intro before, the state of hospice, but this is a state that hospice is in. Yeah.
No more games. No. So let me set you up before we dig in, y'all. We have a wonderful show for you today. So first of all, Dr. Lauren Templeton, she is a previous guest. This is her 7th time on the show. She has her own playlist on YouTube. She is our WeatherBee Resources consultant, and I often joke that she keeps us out of prison because we listen to her. We want to be compliant with hospice care, and they often host and sponsor events with the Hospice Medical Director Certification Board. She has her dream job working with the Pennant group. What's your title over there? I don't even know how to say it.
Oh, it is my dream job to work with an organization that is just so focused on human beings, the human beings that work there and the human beings that we serve. So I'm the Hospice Medical Director for Quality, Education, Compliance, and Advocacy. So basically, all the things I come on here talking to you about so passionately, I get to represent for these agencies across the country. And I'm just thrilled to be with this organization.
I love this for you. And when I go into like nursing homes or wherever, and I see the, what is it, calico on the wall, I think about
Caplico.
Caplico. Okay. Yeah.
They're so about company culture and integrity and just such a high level of compliance and quality. And you know me, that's my jam. High quality, high compliance.
Amen to that. And so, look, it's a little warm over here. We're in the summer. You have any summer plans before we jump in?
Oh, yeah. We just got back from kayaking on the river for my birthday. And then we get to head to the islands for a little vacation with my kiddos and my whole family in a couple of weeks. So we are just like you. I think both of us value family, value life, and we're really passionate about bringing that to all aspects. So let's talk about the professional aspect today.
Period. So I had to get my orange nails after this wedding. Everyone has heard me talk about being mother of the groom. Everything was great. I got my summer hair, so I'm ready for the Guidry family reunion next week. So that's what we're jumping into for the summer. So let's go on. So this is the 100th episode of Dr. G at the Heart of Healthcare. And like I said, Dr. Lauren Templeton has been here with us. We did our first episode about hospice regulatory myths, and we busted them. The last time you were here was Doctor's Day 2025. And what have you been up to since then? Just the same stuff we're chatting about?
Yeah, I think back then I was talking about hospice physician engagement and protecting our beneficiaries with having to engage members of the hospice team. And boy, that's still the message today.
Well, I think if people had listened to you, maybe we wouldn't be in a moratorium. So let's talk about that.
Okay, let's do it.
All right. So on May 13th, I saw that we are in a federal moratorium, meaning not just California, because people try to put us in trouble all the time, but the entire United States of America, our great country, is in a moratorium on hospice agencies. What's up? Why did this come about?
Yeah, so it's not really a surprise that this is coming. We started hearing some whisperings about this might be the federal government's response across the country to try to put a stopgap in place from truly fraudulent participants within the hospice benefit and landscape across the country. So I was actually at a conference getting ready to go on and lecture when I got the notification that the moratorium was put in place. And so that was an interesting time to try to explain to those providers who were invested in their own education and being really high quality hospice agencies wanting to serve communities across the organization, that they were the ones that were being penalized, which is often what we see with these global tactics, these blanket decisions. But honestly, in the hospice industry, I understand there's a need right now to stop some fraudulent activity. But as hospice advocates, we just need to make sure that we're making sure that the people we love and care about, our patients, are getting service that they need to get.
That's fantastic. And so it's for 6 months. I thought I heard in passing that something was kind of taken out or it may have been revised right away. Could you give us uh, maybe anything about what's on there? Like what the details of it? Should we be scared? Like, or who should be scared?
Sure. So it's initially for 6 months. What we know is that they can renew that or extend it, which historically we have seen that before when these types of moratoriums have been put in place. We have a little bit to learn from what has happened with home health in the past about the federal government's perspective on this. So 6 months initially, but that they have the opportunity to continue that. We don't know right now exactly what their metric is in continuing. What it generally is stopping is the opening and acquisition of brand new hospices, and so they're asking for an immediate stop and pause on growth of hospices across the country, and that's wherever. So in locations where we maybe need to pause on growth, and any location that doesn't have access to a hospice right now will be paused on growth.
That's good info. And so when I saw that, I was kind of like, well, good. So now we can stop, complaining about fraud and fraudsters and bad actors and all these stories that take the narrative away from, the sacred care that we do every day. So it sounds like a good thing. But then I heard about what we did in California. And so I needed to talk to my friend. So we have these new emergency regulations for hospice agencies, DPH 18002E, came out June 1st, became effective June 22nd. And the part that stood out to me was it mentions, I think page 83, I should have had that handy, but it mentions that a hospice physician can only be hospice medical director of one agency or designee for an agency. And I was like, excuse me, like, why, when I'm over here leading agencies and laying the foundation as a certified medical director? I was just like, where'd this number come from? So what do you think about that?
Yeah, it's an interesting measure. And for perspective to back up, they introduced some of these emergency regulations about 6 months ago or so. And largely the hospice community responded in public commentary that we had a listening session to say, look at all the problems that this is going to create for good providers who have, the best intentions in providing high quality care. We didn't see a lot of adjustments in response to the public outcry against this. So now we're left to handle and navigate some of the unintended consequences. So the desire here, I believe, not having spoken to them myself, but I think that what they're wanting to stop is the truly fraudulent providers, where we might have a physician who is working with multiple different fraudulent entities so that they can navigate their fraud successfully because they have this person on the insider scoop, right? So when you only have to deal with this one physician working at multiple agencies, they know how you're tackling whatever your brand of fraud is. The problem is that we have a shortage of full-time hospice physicians, fellowship-trained hospice physicians, physicians who have certificates of added qualification. So we're lucky when we have these highly trained physicians like yourself, like myself, who work with multiple different agencies. So now we've gone at both sides of that. Yes, maybe we put some stopgaps in place for the truly fraudulent providers. We've also now put barriers up to the hospice physicians who are excellent, who are engaged, who are attending education and staying up to date on all of these things from operating at multiple different agencies. There's some exceptions to that rule, but largely this is going to be a problem for hospice agencies who are using highly qualified physicians because now they can only work at one agency.
Thank you for that. I was kind of taken aback, and I got a few calls from colleagues, because I'm very, involved in the Hospice Medical Director Certification Board and just expanding our reach and making sure that, fellows that graduate hospice and palliative medicine fellowship, that they choose hospice as a career instead of, inpatient palliative or outpatient palliative. But just know that you could have a good career here. And so I got a couple calls. One individual, this person retired from their internal medicine career, became a hospice medical director certified, and now leads, about 4 agencies in their community. And it's like, so you don't want her to do that? Like, how does that make sense? And I just want to know, like, what's a good number? Like, because we're not involved in the bad actors or whatever, these weird stories that keep going around. I'm just so tired of these stories. I'm sorry. And I'm not denying there's fraud. I know there is, but the people who are committed to our industry, we are out here trying to do our best to lead with integrity and educate these interdisciplinary teams and have them on the right track. So what's a good number? Like, I don't know. I'm just venting here. Sorry.
Yeah, it's such a good question. And I'll give all credit to all the decision makers that are involved in stopping fraud. It's really hard to answer that question. But what we know, a blanket approach isn't the answer that's going to not harm beneficiaries. So let's say, for example, your excellently qualified colleague is working with 4 hospices that are small to medium-sized hospices. That is an appropriate ratio for that hospice physician when it comes to a small number of patients to work at 4 different agencies. One physician who's working at 4 agencies that all have a census of 500, that would be problematic. So an individualized approach, I think, one, starting with the qualifications of the hospice physician, such as asking the physician, if you have experience in hospice care, additional certifications, fellowship training, extensive experience, you can work at multiple agencies. When we see physicians who have inappropriate fraud in their background, when they have been proven to be a provider with fraudulent different, even my computer agreed with my thumbs up there, when they have been proven to entertain into these fraudulent hospices, those are the physicians that should be heavily restricted. What happened here is we put a limit on an already, squeezed resource, which is highly educated hospice physicians. That's only going to translate to harm to the good agencies and our hospice patients.
Yeah, thank you for mentioning the numbers, because I got a little glimpse of them. I think there's about 200 to 300 hospice medical director certified folks in California. I forgot the other numbers, but I did tweet about it, or X about it, whatever you call it, and I put it on LinkedIn to just kind of add some context to this. And also, I referenced Dr. Ira Byock's article that came out a couple years ago that talked about, it kind of laid out 75 patients is a good number for folks. And I was like, you know what? That's kind of a good reference, because, if I have one agency that I cover just 1 week a year because their medical director goes on, vacation, or, every other week I do one, or like my colleague having 4 small ones, that's about that number. And so I really need these non-hospice individuals, politicians, California Department of Public Health, and those folks who don't know what we do to get some references, to get some information. There's a ton of articles out there. So we have that. And I know we're going to get to it, but we have that other article too about, what happened to the beautiful friendship between hospice and palliative care. We need to talk to each other. It's my dream that we have physician to physician handoffs where, no offense against case managers or social workers or anything, but in my opinion, we are the only specialty where a physician is not signing their patient off. And that's crazy to me. Like, I've done social media about it, and I think we need to get to that. So more 2 cents. What do you have to say?
Yeah, I think that number 75 to physician, I don't know that I support that particular number, but what I know is that this requires thoughtfulness. And so if we have 3 hospice agencies that are 5-star agencies that are not in audit trouble and they're sharing a physician, they're performing. They're achieving the quality metrics determined by CMS and with input from our beneficiaries, loved ones, care providers who are receiving the survey with excellence. Why are they the ones that are being penalized here? That's the issue that I take with this, with no thoughtfulness to the rule in terms of those providers that are already excellent providers. We didn't even consult our own CMS resources with this rule. So cms.gov, looking at Care Compare, looking at how these hospices are performing when they share a physician. We should amplify their resources. I work for the Pennant group. I want people to use my Pennant group hospices because I know that they have such a high level of quality and compliance. Even they would be punished in these rules. And so it's just mind-boggling to see that happen. The next on what you said about physician to physician communication, yeah, I think that's another issue. For some reason, palliative care and hospice, they're not besties anymore, and they used to be best friends. We all speak the same language. We all want the best for our patients. We have the opportunity to communicate. I think taking this a step further, what unintended consequences are to blanket regulations like this are distrust, that the distrust is seated within the hospice industry. And look, we already fight distrust in the hospice industry. There are people out there who don't think hospice is a good thing. We fight against that every day. Now it's even worse. So now we have physicians in hospitals discharging their patient who don't know who to turn to. So I would encourage them to get on the phone, just like you said, speak. And you don't have to be a palliative provider to call the hospice. When you call the hospice and you talk to real people, one, that's very confirming. When you Google them and there are 4 or 5-star hospice out there, or in star ratings aren't the whole story. When they have some information on cms.gov, if you can talk to the hospice physician, all of this type of communication will help secure the hospice benefit for those beneficiaries. And that's what we want. So yes, please, doctor to doctor communication, doctor to hospice agency communication. I think that's going to be essential for us to not see harm and delay in referral to hospice care.
Mm-hmm. That is so well said. Um, with the numbers being just not mathing here, I'm wondering if hospice agencies, if they're going to have to scramble and resort to being creative with their staff. I know a lot of agencies, they employ nurse practitioners, which we love, the vital support that they bring to the interdisciplinary team. Are they able to take call or do anything as pertains to hospice agencies?
Yeah, I think that hospice nurse practitioners are such an underutilized, valuable resource to high quality and highly compliant care. Within the hospice benefit, there are more definitions surrounding the role of the hospice physician and how we work as a core member of the interdisciplinary group with the registered nurse, medical social worker, and then our pastoral or other counselor. They're such a valuable added team member. It depends on their state scope of licensure, but if they're able to evaluate patients, give orders, participate. I do think that they have a role here to help assist the interdisciplinary group. They can't replace a hospice physician. The federal guidelines say that physicians are the only one who can certify and recertify as terminally ill, and they're the core member of the interdisciplinary group. So they still have to be a collaborating, there has to be this collaborating presence if we're utilizing nurse practitioners in hospice for more than just the face-to-face encounter. But we still have the problem with finding hospice physicians, and now they can only work for one hospice in certain areas in California. So it's still a problem.
Mm-hmm. Yeah, because I hear this all the time. Teams will say, hey, our hospice medical director doesn't really answer their phone because, they're in their own private practice. They're doing this as a side gig. They have 30 to 40 patients at their clinic and they're moving on to the next thing. So they only have 45 minutes for IDG every 2 weeks. So you have to rush through that. And it's like, why are we in this situation? Like, again, we need to fix it. So let's move on to the next topic that I had here on our notes. How about how does this affect the public in your opinion? I know you touched on it a little bit, about access not being there. I've heard about some agencies having their billing suspended or things of that nature. And we talked about the distrust, but how is the public going to be affected by all this stuff going on here?
Yeah, that's really the sad part of this. Well, again, there is a problem with hospice. There is fraud, and we want to protect these beneficiaries, but we need to do this in a way that isn't causing direct harm. So when a hospice patient is on with the hospice who has their billing privileges revoked for a single data point, which is what has happened in California, and while, yes, that single data point must have been off for them to receive that billing suspension, they still might have been a 5-star hospice. And we've always said in hospice history that I recall that a single data point doesn't tell the whole story. So what may happen there is if you stop their billing privileges and they're trying to continue to provide care, what business can do that? You can't bring in income, but you have to keep providing the care and expending income with no clear end in sight. So CMS has been responsive in stopping some of those. Some of those billing suspensions have not been stopped, even for good providers. So then those patients, when that hospice has to close, is forced to transfer them. Now we're offering them up into the world again in fraudulent hospice land. And now we're offering them to another hospice where maybe we're so scared about the single data point live discharge rate that may affect them in the future. And now they can't admit patients because they're so scared about this single data point. We've really sown a field of fear, and it's not just for hospice patients, it's for hospice agencies, which is unfortunate. And again, we got to do something. So something has to change. Something has to move forward. We have to stop what's happening. I just wish it had been more of a thoughtful approach, individualized. And I would have loved to see excellent hospice physicians be highlighted in this, as them have the opportunity to say, if you're board certified, if you have all these extra credentials, then we can lean into that so that our beneficiaries aren't harmed. Versus the blanket approach that's happening.
Yeah, again, well put. It feels like, and what do I know? I'm no politician or leader. I'm just a boots on the ground person.
Yeah, it's really hard. I mean, I know we don't agree exactly with what's happening. You and I don't agree with what is happening. We agree together on the difficulties, but it's a hard situation. And so I have a lot of empathy to what was the right call here.
Mm-hmm, mm-hmm. And, I'm glad you mentioned about vetting the hospice and just kind of giving context to the data points. Audience, we have covered, how to navigate the Medicare Compare website. So you can put in your zip code and find the agencies in your community and narrow down to according to what we discussed in that particular podcast, we set 3 stars and above, and narrow them down and call them and focus on them. But that's kind of difficult to do in a crisis or if you don't know what's going on. So now we're coming back to advanced care planning.
Yeah.
We need to know that hospice, I'm going to say it again, and I'm going to say it until I stop breathing. Hospice is the final chapter of healthcare. Hospice is the heart of healthcare. That's why I named this podcast this. And you do not need to be afraid of the H word. So lay people, physicians, and everyone, please look into it and understand that. And we're going to keep educating and empowering you so you can make those decisions timely. And so, yeah, let me check my notes and see if there was anything else we needed to say about this, because you kind of touched on everything so efficiently here. Length of stay. Let's talk about that. Someone was on, I don't know who said that, but we all know that former president, late President Jimmy Carter was on for, was it 22 months?
Definitely more than 6 months. So
yeah. And I know the longest I've seen, I think when I was at a corporate agency in San Diego, that person had been on since 2021. Most recently, I saw a 25 benefit period. You said you knew someone who was on for 52? How does that happen?
Yes, they were in. That's a good question. How does that happen? When a patient is in their 52nd benefit period, I think it's much more likely that they've come on and off of hospice, which means they jump into the next benefit period when they come back on. So it's probably not that their lifetime length of stay was that full 52 benefit periods. That's what we think of, that period of time. But where people are more accepting of end-of-life care, and less likely to revoke the hospice benefit. Maybe they change their mind about hospice and they want to go to the hospital and seek, truly aggressive treatment. We're talking ICU, those types of things. When they choose hospice again, they're going to come into the next benefit period. And so if there's a family that's really struggling with that and hospice is doing their best to meet them where they are, they're not forced to stay on. The regulation affords for them to revoke, and if they change their mind again to want to come back to hospice, they can. And so that's a lot of those higher benefit period patients, I believe. Now, have I seen patients on service for a long period of time? I have. Myself have certified patients for over years, 2, 3. I think the longest I've had is over 3 years. At every point, as a physician, I said, I cannot even believe they're still alive. And if I were to discharge them from hospice, and we have data to support this, that a lot of these patients end up in the hospital or the ER within 30 days. So that's a problem. Hospice length of stay is in some ways overregulated and in some ways underregulated. We need, a bridge there for these diseases that lend to a longer length of stay in hospice. They still deserve to have a comfortable death. They don't need to have to come off of hospice, prove they're sick, go to the hospital and come back, which is what is happening when we feel forced to discharge because they're on for a long period of time. It's just a complex story. But what I know the answer to this complex story is restricting really good doctors from practicing hospice. And that, to me, is what's happening.
Wow, that's a good word. So we have romanticized the broken healthcare system. We're seeing individuals choosing not to go with hospice. I'm seeing in my community where people are choosing alternate models of care. Obviously, people with means can do that. We're seeing the end-of-life doulas doing things. So we're seeing a lot of other things. I'm just wondering if we can, all collectively, kind of get together and unify on this. Like, again, I want us to remember that this is healthcare. This is, where else in healthcare can you get interdisciplinary care with a physician, a registered nurse, a social worker, the hospice aide, the bereavement support for 13 months. Like, it's nowhere, and people don't even know that basic piece.
Mhm.
And so I want you all to go do your research, like we research everything else, understand about 6-month prognosis, understand your comorbidities and those things that are leading you to the end of life, because everyone is on their way. We are all
Mhm.
100% on our way, and um just work together to just understand what's going on. And so I want to leave you with wrapping this up. We're coming on 30 minutes. Like, what do you want the public to know about the state of hospice, and just what are we doing here?
I want you to know that there's a concern, and I want you to know that you have the power to address the concern, which means you can call a hospice agency and you can vet them out yourselves. You can look them up online. You can call a home health that you trust and say, who do you use for hospice? What have you seen out there? Is there anyone you would recommend that mom steers away from? You have the power to change this, and it doesn't have to be not to use hospice. I feel very grateful to be in an organization that I think is amazing. Pennant Group has an incredible number of hospice agencies across the country. I think that locally in the community, you would hear from other hospitals or home health that, like, oh, we trust this hospice organization. Get your information. It is important that you use a good provider. Um, and they're out there. The story right now of how bad hospice is the biggest story we're hearing, and it's not the story of who we are as the hospice industry. And we all care about human beings. That's why the good people are in hospice. We care about human beings that are in their most vulnerable time, whether you're the patient or you're the family member that's going through that time with that patient. And we want you to not do that alone. And I genuinely think hospice is the most incredible thing in healthcare, like you're saying, Dr. G. And it just breaks my heart that somebody wouldn't use us because the only thing they hear is about the fraud. We're good. There's so much goodness out there. Um, the end of life is a magical period of time, and you deserve to have that be as comfortable as possible. And hospice is an answer to that.
Amen. Amen. Well, I'm sure we're going to have the opportunity to um, visit the website of our valuable resource, WeatherBee Resources. What upcoming events do you have where hospice agencies can send their physicians and nurse practitioners? We don't call physicians providers. So sending them or anyone else in their team, tell us what you all have up your sleeve to keep us out of prison.
Yeah, I love that. So this has been something that I've been so grateful to do since 2017, is try to model education to meet the needs so that we can have hospice physicians that feel very confident in providing highly compliant care. So we do a hospice physician compliance conference that's virtual, happens on October 2nd. Then we provide individualized training and group training for nurse practitioners. And then, of course, we do our lovely boot camp, and that's in Las Vegas in December. That's an A to Z of hospice care, including addressing the topics we've talked about today: long length of stay, live discharge, audits, how to be a highly quality and highly compliant hospice. All of that's available on weatherbeeresources.com, but particular to the providers, nurse practitioners, I want you to be supported in education. Hospice physicians, I want you to be supported because we want you to lead out. We need you to be leading the charge in really good, high quality hospice care. So please don't hesitate to look at weatherbeeresources.com.
Yes, yes. And then while I have the sitting here, I have the Hospice Medical Director and Hospice Physician Manual. I contributed to one of the chapters about diversity, hospice agencies. Check this out. Like, this is the Bible. Like, this
Yeah.
is like Robbins. This is like Big Robbins in med school. That's how I see it. You can get this, you can read it. It has everything covered. I use this to prepare for the HMDC exam. And this is another resource,
Yeah.
just so you can be compliant. So thank you so much for educating us and celebrating my 100th episode.
It's an honor. I appreciate you having a voice out here because it's hard to connect the dots between what the provider side of the world is and what the public facing side of the world is. And right now we need to all be on the same page, and that's caring about people in a vulnerable time. So thank you for letting me come on.
Happy to have you. Can't wait to see you again. All right, let's sign out on this episode, the
Go
100th episode.
Argentina.
Oh yeah, y'all won. Y'all came back. Okay.
Yes.
Go. So have a wonderful afternoon. We're signing out on the season 4, episode 9 of Dr. G at the Heart of Healthcare, the 100th episode. Peace.